Sheila,
Hey, Val.
change that big old long name I've got on here.
Hmm?
Change that big old long name I've got on here. I was on
Oh.
a multinational call and
Hi, Mary and
Hey,
Steve.
good morning or good afternoon, I should
Good
say.
afternoon.
Been a busy morning.
Yes, I saw that you were busy on email.
Yes,
I,
yes.
w- I
I
was
think
busy.
I like the last version that Nicole sent out. I'm just trying to keep it simple so we don't run people way too quickly.
Yeah. All right. Are we at 1 o'clock, Kelly? Just
We
about.
are, Dr. Schuster. We're at 1 o'clock and you do have a quorum. I just wanted to state that for the record, and I will turn it over to you.
Okay. Thank you very much and welcome to all. I'm Sheila Schuster, excuse me, the chair of the Behavioral Health TAC. And as the pilot says, as you're going down the runway, I hope you're all going the same direction we are. We have a quorum. We have Steve Shannon from CARP. We have Valerie Mudd representing consumers from Participation Station in Mount Lexington, and Mary Haas from the Brain Injury Association of America. And hopefully Eddie and TJ will be able to join us. Mike Barry was unable to join us today. So I would entertain a motion from our voting members for the approval of the minutes of our September 14th meeting. We sent those out in advance. Do I have a motion?
Mary Haas for motion.
Okay, and a second?
Val will second.
Val will second. Thank you very much. Any additions, revisions, corrections? All those in favor signify by saying aye.
Aye.
Aye. Okay, and the minutes are approved. Thank you. We have meeting dates, kind of, for the BH-TAC and for the MAC. Can you share your screen, Kelly, please? Kelly is helping us out today. Erin is homesick, but we're delighted to have Kelly Sheets facilitating us today.
Okay, there it is.
There it is. So we're staying with a second Thursday of the month. And our problem comes up in November. I sent out an earlier version to the voting members suggesting November the 7th at our regular time, but Kelly informs me that there is the optometric TAC meets at that time on the first Thursday. So our choices are to stay with the second Thursday, which is the 14th of November at the regular time of 1 to 3, or move a week earlier. There's TJ. Hi, TJ.
Hello.
And the only reason I had suggested moving it up a week is that the MAC meeting, which usually is on the fourth Thursday, is on the third Thursday in 2024 because of Thanksgiving being early. So it doesn't give me much time to write up our minutes and any recommendations that we have, but it's doable. And since I'm now the MAC chair, I won't penalize myself if I get them in late. So let me ask the voting members of the MAC if you have a preference. Would you rather stay on the 14th at our regular time, or is it all right to move to the 7th at 10 in the morning till noon?
I vote whichever's the best for you. If the 7th works easier for you, Sheila, then I vote for the 7th.
Thank you, Mary. Does the 7th at an earlier time work for everybody? I want to be sure that we have a quorum. I didn't know if moving to the morning is a problem for anybody. That's the first Thursday in November. Steve, is that a conflict for you?
I don't know yet. It's understanding. It's a long way away.
I didn't know if you had any standing meetings on Thursdays.
No, not offhand, no.
All right, Val, how about you?
I mean, a year away, I think I could probably fit you in.
Okay. And TJ, how about you?
Sure, as far as I know, that's fine.
All right, then we will move, Kelly, and I'll send you a final sheet. So it'll be November the 7th at our regular time. No, I'm sorry, November the 7th, but at that earlier time, 10 a.m. till noon.
Okay, sounds good.
All right. The other thing that's on here is that are the dates of the MAC, and I had highlighted that the time of the MAC meeting may change. We're going to vote on that at our meeting coming up. Those meetings are 2.5 hours. If you've been on those meetings, we have been running late every time because we have so much to discuss, and I don't think that the TACs get enough time to really talk about what they're doing. So the MAC is going to meet on the 30th of this month, and they will decide whether they're going to go from 9:30 to 12:30 or from 10 till 1, or in the interest of bipartisanship, I guess, they're going to split the difference and go from 9:45 to 12:45. Which nobody will remember because nobody ever meets on the 45s. But anyway, once we have that determined on the November 30th meeting, we will let you all know. But they will meet on the fourth Thursday of the month in the morning for sure, except on November 21st. Okay. Thank you, Kelly. We could go back to the agenda. When I did the agenda, I put on here the status update on the 1915I SMI. It's actually a SPA, a state plan amendment, and not a waiver. When will the town hall meetings be held? And since then, we have heard from DMS with those dates. Is there anybody on from DMS to talk about the 1915I and those meeting dates?
I'm here, Dr. Schuster.
Oh, great. Thank you.
Let me
Pam Smith is the Director of Community Alternatives for DMS. Thank you, Pam.
I've got to figure out what screen I opened them on so that I can find them again.
Oh, okay.
Let me see. Here we go. Okay, so the town halls are going to be on in here. Hold on, I can
you share your screen,
I can share
Pam?
this. Yeah, that's what I was just looking to
Yeah, because I think it's helpful. And then we could send it out. Or are these posted yet on the website, Pam?
I think Kelly was waiting to get the information about to confirm the reschedule of Northern Kentucky and the location for Louisville, but I'll check with her when we get done. Okay. Kelly or Aaron, can you let me share?
Yeah, you should be able to now.
Oh, now
Pam.
I can. I can now. Thank you. Now it's finding the right screen. Okay, here we go. Let's see. So, if I make this big, if it's going to move it. Okay, let me just get to that screen. Okay. So the first one is going to be in Moorhead at the Rowan County Public Library on December the 6th, from 1 to 2:30. And will you all confirm you're actually seeing that schedule?
Yes.
Okay.
Yes.
And then the
Actually,
second one is in Richmond at Madison County Public Library, which will be the next day. So it's going to be December 7th. Again, all the times are 1 to 2:30 Eastern. Northern Kentucky, I had to tell everybody yesterday that I can't keep track of days and calendars, and accidentally we scheduled one on Inauguration Day. So we are working to reschedule the Northern Kentucky one for, it looks like it's going to be December 11th. So the day before that, we were just confirming with St. Elizabeth to make sure that was going to work. Louisville, we are between 2 locations. The date is the 13th, so I'll find out when we get done with the meeting today. I'll find out for sure if that got firmed up yesterday evening or this morning. But again, it'll be on the 13th of December. And then the final one is going to be in Owensboro at the Daviess County Fiscal Court. So, and it'll be on the 14th. And so I'm sorry, that one is Central Time. So it is the only one that's Central Time. The other four are Eastern. We will be sending out virtual links as well. We were talking with our locations. We wanted to make sure where we held the virtual options that we had strong internet and would have kind of the best connectivity. So I know Kelly was working on finalizing that, and then we were going to send out the links to the virtual options so that the individuals could see those. And we will record. At least one of those virtual meetings so that we can post that to the website as well.
And I think the virtual is being offered, Pam, on December the 7th and on December the 13th. Is that right?
I think that was where she was leaning towards. They were wanting to, her and Will, one of our other individuals working on this, wanted to make sure that the internet and our technology would be the strongest there and would support it, because we didn't want to offer the option of virtual and then get there and it not have strong enough connectivity to support it. But that's what they were leaning for, was the 7th and the 13th, but they were going to confirm those dates when they sent out the actual links that had the to be able to join those.
Okay, and I did confirm with Kelly Claes that email address that's on there, Medicaid public comment at ky.gov, is a good email address for you to ask questions, but also to send in your comments.
Yes,
and all the
absolutely.
Comments, yeah, all the comments will be collected on this version as well as going forward. Is that right?
That is correct. Let me see if I have so we will, as we conduct the information sessions and we collect those public comments, we will collect all of those. And then when we actually enter into the official public comment period, when we post the SPA to be reviewed, then they'll be added together. So really, we keep all of the comments that we get in that public comment box, and we'll add all of it together to be the actual public comment that we respond to. So not just that official or public comment that happens when we post the waiver. We will include the comments that we get during the information sessions. And we're working on a couple different ways to collect the comments or questions during the information sessions. We were working to, one is we'll kind of have the standard, we'll have a card or something where individuals can fill out information and have their question, but we're also working to develop a electronic tool so that we can so somebody can scan like a QR code, and it'll take them to a tool that they can put information in and can submit a question or a comment that way as well.
Okay. Pam, would you back up a slide where you lay out the three kind of main services that are being offered?
Residential ones, yes.
Yeah.
So the three residential, the three housing services are the supervised residential care, so the 24/7 staffed care, tenancy supports, which it offers, those pre-tenancy and tenancy sustaining supports. So, identifying, helping them to obtain housing and sustain that housing by supporting them in, taking care of the obligations that you have as either, somebody renting or owning a house or whatever domicile they're living in, or in-home support. So this is for, individuals that are either living with family members, friends, or they have their own house or apartment, and it focuses on more of the assistance with their ADLs and IADLs.
Right.
So really looking to be person-centered there.
Yeah. And then the next slide talks about some of the other services that you've mentioned before, the supported education and employment. I think there have been some questions about respite, and that's included in that.
That is, yes. So respite is one of those, is one of the services that is included in the SPA, as well as to be expected case management, which, really is the foundation to hold all of it together and to help coordinate and
exactly
to coordinate that.
So this is basically the information that's going to be presented at the town hall with lots of opportunity for people to ask questions in person and on Zoom. Is that right, Pam?
It'll be a combination of this and then with some of the additional information we shared in September on that town hall that talks about the tools, the criteria that'll be looked at, a little bit more of kind of that target, the population will be serving. So a little bit more of the upfront piece. How do we get here? How do you get to kind of through the gate to get services on the waiver? And then we'll also include this. So the services that are going to be on the waiver.
Okay. All right. Well, this is exciting. A lot of people have been waiting a long, long time to see some of these housing services and some of these other services for our folks with SMI.
No, we are very excited. It has been a labor of love, but it's been a lot of work by a lot of people. So we're very excited to see it as we inch closer and closer to when we'll be able to actually put the SPA out there for official public comment and submit it to CMS. So
yeah. Okay. Any questions from our voting members?
Just want to say good work to you and your team, Pam.
Thank you, Steve. Thank you for your support. You and Dr. Schuster have both been vital and been always made yourselves available for questions and participated when we wanted to interview you. So thank you all too.
And we're there to keep nudging you in the direction that we think that people need to go. So we appreciate that. Okay, that is really exciting. Thank you, Pam. And who is on to talk about the status of the SUD services for incarcerated persons or the reentry TAC? Looks like Ann Holland
that would be me ready. Today.
I keep forgetting the name of it now, Ann. It's been changed so many times.
Well,
so
it is reentry.
Reentry.
And so to answer the question that was on here, that the sort of the interviews were finished and concluded in September. It is the application is out for public comment right now. We do I think we're having some technical difficulties with our website, but we're aware of it and we've got someone working on it. So it's posted there. It's going we're having 2 public forums, which are virtual options. One is the 27th of November. It will be from 10:30 to noon Eastern Standard Time, and the other one is December 1st, and it'll be from 2 to 3:30 Eastern Standard Time. So those are the informational sessions about what's in the application.
And what's the deadline for what's the close of the public comment period? And
let's see. Let me think. 12. I think 12 10. December 9th.
Yes. December 9th. Okay.
Thank you, Kristen.
You're welcome.
And have you, I can't remember seeing I don't remember seeing the public forum notice. I'm sure I got it.
I think the link and all of that is in the notice about it being open. All of that information is within that notice. Okay. Kristen, can you confirm I'm right?
Yes, it's all in there. So when you go, it'll give you the options to hit the different links to get to the different stuff. It's all together.
So it's in that posting.
It's in that posting. Yes.
Yeah. So the reentry public forum dates, and those are virtual, are November 27th from 10:30 to noon and December 1st from 2 to 3:30 Eastern Time.
And just an update on our application 1115 for SMI. We have just sent back to CMS some initial questions that they asked.
And that's on the 1115 side.
Yeah, it's on the 1115 side.
So yes, explain to people that are confused about why we have 2 SMI.
This one has recuperative care in it, as well as we're asking to cover mental health inpatient stays for an average length of 30 days. So it'll align with our SUD ask.
Okay. And that's on a different time frame. That's already gone
It's gone. We are in an extension period with CMS on our 1115 overarching Team Kentucky. The name has changed. Authority. They gave us a year, so I think that is to assist them with getting all of our applications aligned on the same time frame, which makes life a little easier for the rest of for us, and especially for reporting.
Right, right. Okay, lots of balls up in the air for folks to think about. So, and some of us are also looking at the home and community-based waivers, which is for a different population, although it includes the ABI folks that Mary is and Eddie Reynolds are advocating for. So we're trying to keep all those balls up in the air as well. Does anybody have any questions? Post them in the chat, please, while we've got Ann on hold here. So we have actually two pieces of SMI. One is the 1115, which has already had public comment and has gone to CMS. And that would allow more days in the hospital. It would get around what they call the Institute for Mental Disease exclusion. It's a terrible name. I repress it all the time. And it will also recuperative care in it. And then the ones that we're just announcing, the town hall meetings, is for actually a state plan amendment, or what they call a SPA, that is a 1915I. And Pam, I think I'm right about this. The I is different than the 1915C waivers, which are like home and community based, or Michelle.
Right. So yes, so the main difference, or the two main differences with the I as the state plan amendment, is that the individuals do not have to yet meet institutional level of care. So they may be higher functioning, and so they would not have to meet the same level of care as someone that would be admitted to an institution. And then the second biggest difference is, whereas in the 1915Cs, there's a cap. So like, for example, Michelle P., you can serve 10,500. For a state plan amendment, it is available to anyone that qualifies, so that meets the qualifications throughout the state. There is not a cap or a limit on the number of individuals that can be served at any one time.
So the piece that we need to look at very carefully is how we describe the target population.
Correct.
Yeah. Okay. And that's how the limitation is done. So it's a very different way of thinking about these waivers for people that are straddling both kinds of waivers, like the community mental health centers do. You know, if you're in the 1915C world with people with intellectual developmental disabilities, people that are dependent on, I just lost the word, oxygen. Anyway.
Ventilator dependent.
Ventilator.
Yeah.
Thank you, Steve. I just lost it. Ventilator dependent are the people with acquired brain injury. The limitations are in the number of slots or placements in each one of those waivers. And in this waiver, there's not a cap on the numbers. The limitation will be on who can meet the requirements or the specifications.
Right. And we'll go, and that'll be part of when we do the forums, when we hold those public comments. That'll be part of what we'll go over again, is that kind of that upfront criteria for kind of both. It's what you do to be able to, you know, pass through. I always say door one or gate one. So I pass through this gate, and then now I look at my services and what services do I qualify for? So that'll be more, we'll talk about the tools and the populations and the criteria.
Okay, great. And then the what we've always called the incarceration, or the waiver for incarcerated persons, now called the reentry waiver, is one that we've been working on. I think Leslie Hoffman and her team has been working on it for, is this the 4th year? Probably. And it would allow Medicaid services to be offered while the person is incarcerated, I had somebody ask me a question. Is Ann, are you still on? Is it both for prisons and jails?
So we're starting where they have inmate medication assisted treatment now. So we're gonna start at like the phase one is gonna be with the state prison. So there's 14 facilities. And then the plan is to phase in the jails as we get availability of staffing and DOC being able to cover the services in the jails. And that is so what yes, it feels like it feels like 4 years that we've been working on it, but that is the reentry application. What you were just talking about. Yeah.
So it's going to start with the state prisons because they have those medication assisted treatment.
Right. They yes, ma'am.
And then you're going to work in, and it's going to include juvenile
to the
facilities too,
that
right?
Yes, that is actually part of this application too, is services for the DJJ population.
Okay. And do they start out right away also? Do they have those services if the kids need MAT, for instance?
Mm-hmm. It's the same. We're asking the same what we're allowed. I thought somebody was speaking. I'm sorry. What is allowed with adults is what is allowed with the juveniles. CMS is going to come out with more guidance in the first of the year around the juvenile justice population. So we'll see. And Deputy Commissioner Cecil's put some information in the chat as well.
Thank you very much, Veronica. And it's is it 60 days pre-discharge or release?
That's what we're asking. Yes, ma'am.
Yeah. Okay, great. Wow. I know that we're still a long way from seeing these waivers being implemented, but it's exciting to have so much going on and moving ahead. Poor Steve's been running the reentry TAC for what, 1.5 years, Steve?
Long time.
Without much to talk about, but it's coming.
It is coming.
Yeah, and this is an important population for us to be dealing with. So thank you very much. And thank you, Veronica, for posting some of those comments in the chat. That background is helpful. If there are not any other questions about waivers and so forth, we had a whole bunch of questions about Medicaid rates for behavioral health services, and I don't know who's handling that. Looks like Justin is, and Ann.
Well, I'm going to listen and try to help if I can, but Justin is definitely, I think, around the report.
So, hi, this is Justin Derringer, and I wanted to go over, it looks like on the agenda where you had asked about some of the processes, input from providers, what rates are being finalized, the Senate Joint Resolution 54 report, some of those things. So I was just going to touch on a few of those topics.
Great.
And may be able to go into a little more detail about any specific codes as that fee schedule resides in with her, but that they're looking at. But as far as the process for rate changes and what we do on an annual basis as we come up to January 2024, we receive a list of changes and updates from Medicare. We have depending on the provider and the fee schedule, that has a formula that goes in that gives a percentage of Medicare's rates to the fee schedule. And so then those fees are changed based on that. There are also codes that are added or deleted because of that. And then throughout the year, we have, I get somewhere, it just varies. I think I haven't got any today. So, but sometimes I'll get up to 20 a day of requests to add codes, change pricing, raise fees, or remove codes or adjust limitations. Those are reviewed and researched over the course of the year. We look at other states' fees. We look at their fee schedules, see what they're being paid. Other states' Medicaid programs, we look at Medicare, we look at private insurance, and we compare and contrast. And then we look at our own budget, our own fiscal analysis to see what we can and cannot do. And then we run that, up the ladder and see what we can get done. And we try to compile all of those, unless it's an emergency situation that we feel like is going to impact the health of Medicaid members. Then we may do that, at any point during the process. But those are usually kind of compiled to the first of the year. So a lot of things that we've done research on that we've been asked by providers to look into, whether they be a fee that is not adequate to provide the service, meaning it doesn't pay enough for the provider to actually do that. Or whether it's a code that needs to be added or one that needs to be deleted. A lot of those things will be done at the first of the year too. So all those things will come out for the first of the year fee schedules. Right now, we don't have any fee schedules that are have any blanket increases or anything like that, because we haven't had, that was not in the budget to do that. We have finalized rates for those fee schedules are usually sent out to providers as soon as they're done around the first of the year. As far as the input from the providers, that's done kind of throughout the year with the information we receive from them. We receive that information from various TACs sometimes, but usually from individual providers or provider groups. And once we make a decision on those, what recommendations they send us, we always respond back to them and let them know the decision that we made and why we made it. There are several actual rate studies on different groups of provider rates. I know, for instance, one right now is therapy rates, looking at therapist versus the state plan therapy services versus EPSDT therapy service versus waiver therapy services. That is a in-depth study that's been going on for a few months now, and we hope to get some completion here toward the end of this year. But anything that we do, we will on that study, where it's an overall large study, we make sure that we get provider input, usually by submitting that and discussing that with technical advisory committees. An example of that is we're currently working on, or we just finished up a rate study for the inclusion of contact lenses. That rate study was completed, and we gave some fees and pricing on some of the different new contact lens versions of contact lenses that were out there, and that went to the optometric TAC to get their comments and views before any changes were made. So we work with various providers and TACs and getting input from them in the same way that therapy rate study would have the same type process, where we would send that out to the provider groups or provider representative before we made any kind of change, where it would be an overall change. We're making the large group of codes. So that's, I think I kind of maybe, the report 54, the preliminary report was completed. It was a two-part report. One of them was due earlier, and that was completed. And then the other one is I think coming due, and I think they're about done with that one. So that will be made public when that's complete. And as far as the last agenda topic, it looks like 24 behavioral health fee schedule. I think I saw there. I'm gonna let Ann talk about that one, because that's kind of not in my wheelhouse. But
yeah, Justin, let me ask you about the Senate Joint Resolution 54. At our last meeting, I think Leslie said, "Oh, I need to send you all the report on Senate Joint Resolution 54." And yeah, Kelly just put the front page of it up. So the date on this is July 15th, 2023. Is that the first part?
That's the first part that was completed. The other one part was due July, and then the other part was due
November 1. Hi,
there,
this is
there you go.
Veronica. Yeah, Veronica Judy Cecil, Senior Deputy Commissioner for Medicaid. Just to chime in a little bit. Yeah, so it was a two-part request. One was due July 15th, and that was on the rates, the pediatric therapy rates. And then the second one we just released, that was early November, and that had to do with a specific request about is there a way to use area deprivation index to develop rates. I think the request there is to maybe how can we look at rural areas and do rates differently based on that. So the second report we just completed and sent out. It's very intense. So, and probably deserves its own time slot for, if you all, once you all review it, maybe what I suggest is you all review it, and maybe if there are particular questions, we can come back or even do a small presentation on it at the next TAC.
Yeah, that would be good. I think it was Commissioner Lee that, and maybe it was Leslie, I honestly don't remember, that sent me this report, which is about a 6 or 7 page, the one that Kelly has up, and it talks about audiology, behavioral health, and then occupational, physical, and speech therapy. And I didn't realize that it's all for pediatrics. Is that right?
That was the specific request from the SJR 54. Yeah.
Okay. So I know that we have people that do behavioral health with pediatric patients. So is that posted on the CHFS website someplace?
So we don't normally post these, but whenever
we can send it out. I mean, I can send it out because I've got it now, and I could ask Kelly and Aaron to send it to whoever they typically.
Absolutely. And then what we generally do for anyone that is not a MAC or TAC member, because we've discussed it, we'll post it as part of the meeting documents. So following this meeting, when we post the YouTube, and when we usually follow up with any presentations that are discussed within the TAC meeting, so we'll post these as a follow-up to the discussion that we're having today.
All right. So we can go to where the YouTube is posted, and then the documents discussed in the meeting would be there as well.
Yeah, to the TAC page where we put the agenda, and usually we put any presentations from that. So it'll be on the TAC page.
All right.
Yeah.
So let me just say to those who are on the Zoom right now, if you get emails from me about the TAC meetings, then you will get this report from me. If not, please send me an email. It's kyadvocacy@gmail.com, and I'm happy to add you to my list. What about the most recent report that was done, the dense one, Veronica? Could somebody send that to me?
Absolutely. And I thought that is what the commissioner sent to you. So
no, the one I got was the one that
for the therapy.
For the therapies, and that's helpful because it does have behavioral health in it.
Yep.
And we do have, as an old retired child psychologist, I'm glad to see the pediatric patients being looked at in particular. I was curious, Veronica, because it says that they compared those rates to other states, but I didn't actually see the comparison in the report itself.
I
have to say that I glanced at it quickly, but I
thought we did include some data, but it's been a minute since I've looked at it.
Well, and I did one of my very late at night, glancing through it. So maybe you and I can look and see whether that, because I would be really interested in that state comparison on those rates. Okay, and then there was a question in the chat, and I didn't see it fully. I think it was from Kat Jones.
Yes. She says, will the BH fee schedule continue to be updated on a 4/1 versus 1/1 update schedule?
And yeah, I'll have to excuse me. Somebody is knocking at my door. Can somebody answer?
Sure, we can take that. And I don't know that there is there a intent to move the there is. Okay, so permanent.
That has been my ask.
Okay. I think, and one of the reasons for that is, as you all who do work in reimbursement know that we are always trying to play catch up when CMS makes changes to the fee schedules. We don't get a whole lot of notice to incorporate those changes into what we do. And so I know for the behavioral health, especially, CMS sent out the first changes to us and then sent out a subsequent one, which really caused us to have to really scramble to get that updated. So, excuse me. So I think we are playing with the idea to be able to instead of have to do retro anything, is just to give us time to implement those. Excuse me.
So what would be the new time frame, just so we all understand?
So in April 1
Okay.
Is what we're contemplating.
Sorry about that. I've got somebody wants to lop off dead branches in my tree. You know how when you're working from home, various things come up.
Yeah.
All right, Kat, does that answer your question? Are there any other questions about the fee schedule? Bart,
Yes,
you look like you're unmuted.
Yeah, so just a quick question on that. I mean, I, to have it at a set date at 4/1 versus having a retro would be great. You all have heard from me a lot on that, so certainly that would be nice. And especially if you give yourself enough time that it's posted prior to 4/1. So you know, I mean, it may not be effective 4/1, but it's enough time for the MCOs who follow this fee schedule. I know they're not, you know, they don't have to or not, you know, but they do. So that's what we run into some issues too, is if it's out in advance enough that for billing straight Medicaid, you can start doing that on 4/1, but enough time so that the MCOs can load that so that they can start billing the correct rate on 4/1 to the MCOs as well. So, and I'm sure that's part of the plan to moving it by 3 months. So hopefully that will help. Thank you.
Yeah, it is. We want to give everybody plenty of notice to prepare for the change, as opposed to having to notify everybody that, by the way, you know, we've just implemented something retroactively
2 months ago. Right.
So we really want to align all those effective dates, both for fee for service and MCO, to the extent possible.
Great. Thank you. Thanks, Sheila.
Yeah, sure thing. And thank you, Veronica. That's very helpful. The only other thing I would say, I guess back to Justin, the question about how rate studies are done and so forth. That question was really came up because I got contacted by a SUD provider about the rumor was going around about changes in some of the provider rates. And they asked me the question about, you know, is there any way to know that these things are being looked at before they get solidified? And I guess that's always the provider, and in some ways the consumer question. And I don't know if there's a solid answer for that. You know, if you all are doing a big formal rate study where you're going to send out surveys to providers and do that kind of thing, like I know has been done on the HCB waivers and some of those things. But I guess the question is, when something kind of percolates with you all, I remember years ago it came up around services and the BHSOs. I guess I'm trying to figure out how we can have better communication so that providers and consumers could be in touch with you before things get decided.
Yeah, it makes it difficult because of the volume.
Right.
The amount of research that we do on a daily basis. Um, the amount of requests we get daily. We have hundreds and hundreds of research projects going on right now. All different provider types. Some of them, most of them are wanting to add codes. A lot of them are wanting to increase rates. There are a few to remove codes, and then there are some that are on like limitations, modifiers, those type things. So I don't know, I think it would be very difficult to do for every little thing. Now, the most that's going to affect is just a few codes. Um, so like I said, whenever we do a big, for instance, that therapy study is one, and the contact lens study, those are big studies that involve a large number of CPT codes changing. And so that is always pre-communicated. We'll definitely make sure it's communicated with the TACs. And we also try to get any other, large provider groups involved before that's kind of finalized and put in stone, so they at least know what's coming before it comes. So, um, I think we're, you know, I feel like our communication there is improving and going to do better, and you all won't have any big surprises like that. But as far as like changes, to small codes and maybe limitation on one CPT code or something like that, I mean those things are going to change, and we're always, whether you could probably name 5 codes, and I can almost promise you one of the codes we're doing research on right now. So
Yeah.
Yeah, I think. Go ahead,
Well,
Veronica.
I was just say, just to add to that, we're generally in a position where we have gone out and made kind of sweeping changes not related to Medicare fee schedule changes. Because we've had providers come and ask us for that. And so I think there's a lot of things that does kind of maybe happen at that level and not more publicly, general public ways, because we're working directly with the providers that are affected by the fee schedule. Sometimes it just to be very candid, is it's out of our control. So we might get a request from leadership to do something, and so we're working with them, and we're not at liberty to really be very public with the information, and then those decisions get made very quickly, and a lot of that is really, we hope, towards improvements. I think the dental vision and hearing is a good example of, we did not really, even though it had been discussed at TAC meetings and in general, we didn't have a lot of time to really put that out there for public comment before we needed to implement. So, we are trying to be better about that. I think major changes to the behavioral fee schedule, the therapy, the therapy TAC is talking about the report and overall increases in the therapy rates. Those are things that we are having those conversations with. But ultimately, these do have, most of them have significant budget impacts, and we have to go back to leadership and have them, make final decisions. And so that it's just doesn't really lend itself to have big public comments, So we just, as Justin mentioned, I think we just really work on a kind of case by case basis with the provider type that's being impacted by that.
Okay. I mean, I understand that when Justin talked about getting, on a single day, 20 different requests, it kind of puts it in perspective in terms of the volume. I guess the providers would say, it's the old thing about the surgeon saying, this isn't going to hurt much. And the question is, it's not your body. If you're if your axe is the one that's getting gored or your ox is the one getting gored, then you're going to be on it, even if it's only one code that's being changed or whatever. I think I guess I would just make the request that if it has anything to do with remotely with behavioral health, that you would use our TAC and do the same. And I'm sure you do that with the other TACs as well. And so we appreciate that and appreciate you all being on. So thank you very much.
And we will definitely try to do that. I know with SUD, because we've got a process set up with our SUD providers that we provide them regular communications. And when we are considering changes to the fee schedule, we always do try to get feedback from the providers about how it's going to impact them. Generally, if it's an increase in rates, there's no problem. But it's when there's a decrease in rates that, it starts to get a little sticky. But so for SUD, there's kind of a process for that where we've been working very closely with the providers through that process, but certainly could bring that to the behavioral health TAC too when those conversations are happening.
Yeah, I mean, I think obviously we're concerned about both mental illness and substance use disorder. So if there's a way to get that process in place around the more, if you will, psychiatric or the more mental illness kinds of, and those providers, the BHSOs, as opposed to the AODEs, I guess, the CMHCs have a foot in both camps, obviously. But yeah, I would think that the mental health providers would be very interested in that same kind of process. All right. The next question was about information from DMS on plans to expand the use of behavioral health associates to other behavioral health provider types in addition to the CMHCs. Is that you, Ann?
Yes, ma'am.
Thank you.
So we're working on guidance that's going to come out soon. Once we get it drafted, we send it to our leadership for approval. But I would say that not giving out dates. I learned my lesson early from that in this TAC, actually, several years ago. It'll go live, so to speak, or be available in 2024. But it is a person with a minimum of a bachelor's degree who is working towards a master's, or a master's working towards a PhD. And it's also a person that may be working towards a credential such as a CADC. Minimum, as I said, a minimum, they have to have a bachelor's degree. And then the provider type expansion is it is for outpatient services only. It's for tier 1 and tier 2 BHSOs, behavioral health multi-specialty groups, the certified community behavioral health clinics, which is a demonstration we're doing, community mental health center, a federally qualified healthcare center, a rural health clinic, and then on our crisis, we're going to be adding 23-hour crisis stabilization. They can also work in that setting as well. There will be an application process that's turned into DMS. We've established a specific email box for that, and Amanda Taylor, it also goes by Mandy, will be the person that will be the oversight of that. So we do expect a big flux at the beginning, and it'll be all hands on deck to get them out. As I believe we said 14-day turnaround on our end. So and as soon as we get the approval for the policy guidance, then we will issue that and give a date of when to start doing applications. And I see a hand up from Stephanie.
Stephanie. Yeah.
Hi, Ann. Good afternoon to the BHTAC. Regarding the application process, and it sounds like you're saying DMS is going to house that information, how will the MCOs be notified of the approval of the certifications? Is that a report we'll receive, or
I think it'll be similar to how we notify you of the self-attestations.
Okay.
That way. And then the provider would need to keep that documentation, that approval letter, in that individual's file. There's a process if the person leaves the facility and they go to a new one. There's a process. All of that is lined out in our policy. The rate will be the bachelor level rate for the services, and we're going to use a modifier as well. I don't have the modifier. I don't want to give it out. I don't want to give out the wrong one, but there will be a modifier with this.
Is there already a bachelor's level rate? And
yes, ma'am, there is.
Okay.
Yes.
Huh. Okay, I don't do billing, so I didn't know that. So Karen Garrity, let me just read your. Karen, you want to come online?
Yeah, sure. I was just not sure about the this is not about what we're talking about, but going back to what Veronica Cecil said about regular communication with SUD providers. I just wasn't sure when or how that was happening, because we have plenty of SUD providers and I wasn't familiar with this regular communication.
So Anne might have to help me, but so there's a newsletter I know that goes out regularly. And when there are changes to the program, there are emails that go to the providers. We have a distribution list. Is that right, Anne?
And then a lot of the communication is with the self-attestation for residential. There's a lot of back and forth with that. To be honest with you, I don't think we've done a newsletter in a little bit, so I will. I will get back on that. We'll circle back on that, but we do have a distribution list, and it does all go back to when we got our 1115 and the ASAM requirements that we use. But I do want to say this: there are new criteria for ASAM, and so we'll be communicating going forward on some of that as well.
If we wanted, if I wanted to put my email on the distribution list, who would I contact?
You can send it to me and I'll make sure it gets sent.
All right. Thank you.
Okay. Anyone on this TAC, by the way, if you want to be on a distribution list that we have for substance use disorder treatment, you can email me your contact and just tell me, make sure you say to me, because I will forget why I'm getting an email that it's for an SUD distribution, and I will make sure that you get on the list.
Can you drop your email in the chat so that we have the correct spelling?
Sure.
Thank you.
And Kat Jones has a question about the rates. Kat?
Right, and I may be misthinking, but I was trying to remember. I don't remember a bachelor's level rate, for example, psychotherapy.
There is. There is.
Oh, there is. Okay.
Yeah. At least on the fee for service fee schedule, there is.
Right, fee for service. I was thinking on the BH fee, Medicaid fee schedule. Okay.
Yeah.
There's not. Yeah, right.
You mean Medicare? Medicare?
Medicaid. Like, for example, 90837. The licensure would, I believe the U4 would be your associate under supervision, which would still be a master's level individual. I don't remember a bachelor's level rate, but I could be totally. Or CADC would be a U6.
That is a rate for someone with a bachelor's degree.
Got it. So it'd be CADC rates. Okay.
Right. Yeah.
Got it.
The column 5 is would be the bachelor's level rates.
Right. So for services that a CADC can't provide, I'm not sure off the top of my head which ones there would be. There might need to be some things changed on the fee schedule. Yeah. Okay.
Well, they should be doing, like, a CADC cannot do mental health under that credential. So
Right.
that would be communicated and to be understood that you can't use that credential to do mental health psychotherapy, only
Right.
substance use. Yes.
Okay, any other questions? So I think you said, Anne, that you're going to be sending out guidance.
Very detailed.
Very
Yes.
detailed guidance about the
Yes.
BHAs.
Behavioral health associate. Yes.
Yeah. And DMS is going to be in charge of accepting the applications and
Granting
this, granting the
yes.
credential.
And I will say it will be they'll get this for 5 years. So we had some back and forth with our sister agency, Department for Behavioral Health, Intellectual and Developmental Disabilities, about the policy. I believe it was shared out maybe to Mr. Steve Shannon, possibly. I think you've eyeballed it before. It's been a while. So
and we like the 5 years. We think
yes.
that's fair for folks. The initial time frame may have been 3, and we didn't complete their master's program in 3
so
years.
There's no, I mean, 5 years is it. That's all. That's, it's not like you can apply for another 5. It's like a lifetime allowance. Okay.
So the idea being that people are in school moving toward that degree, that we really are more comfortable with people doing these.
It's really our way of trying to help the work. We hear everywhere about the workforce shortage, and just recently I heard on the news about the paramedics shortage in Kentucky. So it's everywhere. So this was a way for Medicaid to try to assist, as in, and as you just said, get clinicians out there and trained and working.
So I'm assuming, Anne, that the guidance that you're going to be issuing talks a lot about supervision and those requirements and who has to be the supervisor and so forth.
So I can speak from my College of Social Work. When you're in school, you have your educational piece that has supervision, but you also would have to have a master's level. But for billing Medicaid, it would have to be the license enrolled as their billing. So you will have billing supervision for us, but then you have your clinical side as well. Does that make sense?
Yeah.
Now Bart's got his hand up.
Yeah, Bart.
Yeah. So quick question to clarify, you said column 5. I pulled up the fee schedule. So that's where you need to look at what the fee would be.
The rates, the reimbursement rates for fee for service.
For the BHA.
Yes.
And back to that question you were just talking about in terms of the licensing boards, because I don't know that there exists. I mean, it may be a billable, but I think speculate there would be
education. Education. All right. I'm sorry. Let me hush and let you finish.
Yeah, no, I know what you're talking about as far as education. They have to, in order to get their supervision to move towards being able to sit for licensure and those types of things, but in terms of, would it put individuals at odds with a license forms that says you can't do this therapy without a master's or an associate? You see what I'm saying? So I think
I do.
There probably need to be changes. I mean, those regs I don't know nearly as well as some of these, but on if it's the social work board or marriage and family
social work board, especially BSW,
yes, they
prohibited. Yes. LSW is really licensed social worker, so that would be something that that cadre of folks need to really understand.
Right. Yeah. So if they have a bachelor's, they would still need a license, even like you just said, an LSW, and working towards a master's. They have.
I think their board says you can't do that at the bachelor's level. It is prohibited for a bachelor's level. No. So some folks have gotten in trouble over that.
Yeah. How will the guidance be distributed? It will be we'll send it out in a provider letter. The guidance will come out in a provider letter.
And there'll be a regulation, I suspect, right?
Which, yes, it's Jonathan's probably not on here to speak to that.
But it will go through the public comment process.
Yes, it will. Yes, it will.
Okay. And Michelle, you have your hand up.
I'm here, Ann.
My question was regarding the licensure boards, because this using bachelor's level folks in a clinical manner would be against many of the licensure boards. So I just wanted to see where we were in talking with them.
Ian, can I say something real quick?
Yeah.
Yeah, sorry. So the college, not college, but the Board of Social Work has now put out a temporary CSW. So that would be the perfect person that would apply for a BHW. I mean, a BHA. For instance, and then of course the temporary CADCs. This is a perfect example of someone that would apply for a BHA status with Medicaid.
But is a temporary CSW already have a master's degree?
They do have a master's degree.
Well, the BHA may not have a master's degree. Yeah. Yeah. The CMHCs have used MHAs for a very long time. And we are really concerned about those folks with a master's in social work because their board has some, I mean, to date has said no. Maybe that will change and maybe there's another option. But right now, so that's an area that we're always paying attention to with those bachelors of social work folks. But a bachelor in psychology, I think it's sociology, human services, can clearly eligible right now to be an MHA. And from our perspective, the new requirement is enrolled in program and limited to 5 years.
Yeah, I think we will. I mean, it's not here yet, right? I think what we can do on our end is we can reach out to the licensure boards and show them what we're proposing and get feedback from them. I will say if you all have any pull with getting them to respond, that would be most helpful. Sometimes we send things out and we don't get a response back from licensure boards. So I think that's the route we should probably take before we go live with this, is to send our proposal out to the licensure boards, behavioral health practitioner licensure boards, and get some feedback.
I think
that's all I was raising, and just to be sure that.
No, I appreciate that. I appreciate that.
Yeah, I really think that's the way to go, because I'm not sure, for instance, that the Psychology Licensing Board, which is called the Kentucky Board of Examiners of Psychology, KBAP, will approve a licensed psychologist, either at the master's or the doctoral level, supervising someone to do psychotherapy who doesn't have at least a master's degree, which is the issue that I think the social work board is going to raise. I mean, that, the master's has been the lowest level of licensure for someone to do what we have traditionally called psychotherapy. And there are lots of other things that bachelor level people can do, but just like they would not allow a bachelor's person to do psychological testing. Yeah, Ramona says bachelor level RNs can't either. So
right. I think there will be services that they won't be able to perform, and ultimately, we always say within the scope of your, what you're allowed to practice. I think Anne brought up a good point about the licensing boards. If we don't control them, we understood there was a need for this. We're trying to fill that need. If willing, there should be a groundswell from the providers, from you all, the practitioners, going to your licensing board and said, this is something we need. Can we have a conversation about it? Because we can only do what Medicaid is able to do. And then we always say, if your licensure permits you to do this, if it's within your scope. So, if again, we felt there was a need for this. I think we all have to work together if you really want to see this come to fruition and be what people want this to be. So it's a good to know.
Well, I mean, I would say that many years ago, there was something called an MHA, mental health associate, and bachelor's level psychology, bachelor's in psychology. Sheila, I know because I was one before I got my master's. You could bill.
Yeah, still today at a CMHC.
Yeah, in a CMHC. This is when I was working at 7 counties long ago. Yeah, so it's been around a long time. I mean, it was around a long time ago, put it that way. And I guess, has it continued, Steve, in the CMHCs then?
Yes.
Yes.
So are they, I guess my question is, are they billing were you billing for doing psychotherapy?
For good or for bad, yes.
Yes.
But I think it, I as Ramona commented in the chat, I think it's a valiant effort to try to address some of the workforce issues.
Yeah, I agree.
I guess my question is, are there things that a bachelor's level person who's working on their master's can do that is helpful in addressing our workforce issues, but does not include what I think of as psychological evaluations or psychotherapy?
No, I hear you.
Functions.
But they would be under supervision, and hopefully more complex cases would not be going to those individuals. But that's another issue.
Yeah.
But it is in existence at the CMHCs already.
Yeah.
Oh.
Michelle, you still have your hand up. Or do you still have a question, or is your hand still just up?
She's also driving.
I just asked that question about licensure because what we need is therapists. And I just know the licensure board do not want bachelor's level folks doing therapy because they're just not qualified. They just don't have the education and information at the bachelor's level to provide therapy. And so I just didn't know what they were saying about this change that we were doing. So, but yeah, I don't know if I can take my hand down.
Oh yeah, it's down now. So yeah, I just wanted to be sure. So Anne, let me know when you're ready to reach out to the licensure boards, because I have some working relationships with a lot of the behavioral health licensure boards.
I will. I may even CC you on the communications. How's that?
That would be fine.
Thank you.
And I do think that this came up years and years ago. Back when we had two different cabinets, the cabinet for health services and the cabinet for family services. And I remember being in a meeting and saying, you have licensure boards that are set in statute and they really have purview over this. Mm-hmm. And I do applaud Anne and Veronica, the desire of Medicaid to help with the workforce thing. I think we just have to be really careful about who's out there doing what.
Right.
We don't want people to get harmed in some way or think they're getting a service that they're actually not getting if the person just is not ready to give that service. I guess that's where I'm coming from. So
I assume that a licensed professional would have to sign off on everything. I would assume.
Yeah, and that's my question, Kathy, from the the board perspective.
Yeah.
If you're, are they gonna see that as, aiding and abetting the unlicensed practice of social work or psychology or whatever? I mean, that's where the boards are going to be coming from. And I think that's going to be the question. So, and we've run into this, as Michelle knows, and Kathy Adams and Steve and I go way back with the social work board over some of these issues for a long time.
And they've come to Medicaid in previous years about some of it as well.
Some of these
when
things.
I first started in behavioral health policy.
Yeah.
But it's time limited, right? 5
yes.
years. And assuming one is, I think you were saying that they need to be working towards something more.
Yes, ma'am. Yes, ma'am.
Yeah. All right. Well, that was a simple discussion. Thank you very much. nothing is simple in behavioral health, I think. Justin, if you're still around, my question was, have all the providers been notified that your dashboard is up and running?
We've tried to talk about it in each of the TACs, and but as far as a formal provider letter, that provider letter was sent today to our contractor that sends out those letters. It
Okay.
also went to the MCO branch today to be distributed to the MCOs, and it went to our online specialist to put on the website. So those they went. I think it was about 10 o'clock this morning that went out to each of those groups. So any day now within the next week or so, providers should start getting that letter, and that will pop up on our provider letter website. So.
Great. Well, this is great timing. All right. Today's
Absolutely.
the day.
That's right.
All right. Hooray. Thank you. Thank you so much, Justin. You have really labored. I don't know if it's been a labor of love or frustration for you, but we're really glad that it's at least up for the providers. Appreciate that. Pam Smith, if you're still on, we had a question about the 1915C waiting list numbers.
I am here. Let me see. Let me get my screen back up. That's got that on there. We have 2 waivers that currently have a wait list. So, and these are numbers as of Monday the 13th. So Michelle P.
Are you sharing your screen?
Oh, nope, but I can do that.
Okay.
I will do that. Oh, okay. Let's see. There we go. Okay.
And while you're doing that, Bart says there was a regulation filed November 13th for the BHA. Is that right, Bart? The Behavioral Health Associate?
Yeah. Yes. I had somebody send it to me just earlier today.
Yeah.
Okay.
That's right. We're in a 75-day comment period on 907 KR 15005.
75-day. Is that what you said, Jonathan?
There we go. Sorry, I got my mute stuck on. Yes, we'll be in a 15-day comment period the rest of this month, and then it'll be 2 months after that.
Oh, okay.
It should be hitting the LRC website soon if it hasn't yet, and then we've sent out our Red Watch email today.
All right. Thank you. And thank you, Bart, for that heads up. Sorry, Pam.
Yeah, I mean, it should be out there.
Oh, no,
on
that's
LRC.
fine.
That's how I got it. So, yeah.
Yeah.
But yeah, so comments would be due late January.
Yep.
In the January.
Or go ahead and send them so you don't forget, because we run into that sometimes too.
Yeah, if you give us too much time, Jonathan, we don't know what to do.
Yeah. Jonathan would rather have more as we go than all of them on the last day, right?
Yes.
Sure.
Yes.
Thanks.
Okay, Pam, we're fine.
Okay, so for Michelle P, so we only have 2 waivers right now with a wait list. Michelle P, as of Monday the 13th, it was 8,781 total on the wait list. SCL, we were at 3,356 total on the wait list. No one in the emergency category, 81 in the urgent, and 3,275 in future planning. And I'll go ahead and share the extra stats that like I did yesterday, because I think it's important to know, because those are big numbers. But when we look at Michelle P, so 84% of the individuals that are on this wait list have Medicaid eligibility, which means they could be receiving some type of services. They may be in an MCO, they may be receiving them through state plan, but they do have Medicaid eligibility to have access to services outside of the waiver. Then also within that group, we have 25% that are receiving services in a different waiver. So they remain on the Michelle P. wait list, but they're receiving services in one of the other waivers. And a smaller percent, we have 4 that aren't receiving services yet, but they're in the process of getting there. They've had capacity assigned in a waiver, and they're just working their way through the process of getting a prior authorization for services. For SCL, 93% of the individuals on the wait list have Medicaid eligibility. 65% are currently receiving services in one of the other waivers, with another 10% that are in the process of completing that enrollment in a different waiver. So they are either getting their level of care done or developing that person-centered service plan to get to the point where they'll actually be able to receive and bill for services as well.
Okay, so those are stats that we've not had before, and I appreciate that, your ability to go back and kind of look at those individual cases. So for instance, for Michelle P., you're saying we've got 8,800 people on the waiting list, but 84% of them have Medicaid, so they are getting some Medicaid services.
Mm-hmm.
And another 25%, so a quarter of them, are actually getting waiver services in a different waiver, a different kind of waiver.
Correct.
So they could be an HCB or something else.
Yeah, most of them are in HCB. We do have a few that are in SCL. It's kind of a bizarre. There's this lore around Michelle P. that it is kind of the end all be all of waivers. I don't know what exactly caused that to happen, but we have some people that are on, that are actually receiving SCL services, but they do not want to give up their spot on the Michelle P. wait list. And so we don't, because usually the goal is to get, it's kind of a bridge. You get Michelle P, and then later at a time where you're going to need residential or need more intense services, then you go to SCL. But there's just this kind of idea about what Michelle P is that cause some of those individuals to not want to give up their spot on the wait list. We verify every year. We, check their demographics. We check, follow up with them. Are you still in the state? Do you want to remain on the wait list? And so unless they ask us to take them off the wait list, then we do leave them on the wait list. So.
Okay. And then the 4% that you talked about, Pam, are in process of getting enrolled in Michelle P?
Mm-hmm. Yeah, so there are 4%. So for Michelle P, there are 4%, and SCL, there are 10%. So what that means is they've been given a spot, so they've been allocated a spot in the waiver, and so they're in the process of getting their level of care evaluations, setting up their team, getting a PA established. They just have not started receiving services yet.
Okay. So, and the same thing, although in SCL it's 93% that have Medicaid. And another 65. And I assume most of that 65 who are getting it in other waivers are on Michelle P.
Yeah, the majority of them are on Michelle P. There are a couple that are I don't have the exact number. That was a bad word to use. Some that are in HCB, but the bulk of them are in Michelle P.
Okay. And then
we actually
10% that are getting enrolled.
Right, that are getting enrolled. They've been given in their slot, and so they're just in the process of getting all the way through all the steps to actually have an authorization and receive services. I don't move them up to that other category until they actually have received. We know they are actually receiving services.
Okay. Any questions? Mary, you have any questions about those numbers?
I have a couple questions. Pam, I know you say what's on the wait list. What are the actual numbers for ABI waiver? Because I was given, I don't know if there were some people in transition, but there were 4 people waiting for the ABI long-term care. And then I'm working on another project right now and have been out to see some of the ABI waiver providers. And they're telling me that there's some holdup of getting people into the acute waiver. Do you know what they're talking about? And can you give me those exact numbers on ABI, please?
I have no idea. So, so if you can find out, Mary, and you either have them call me or you let me know. But for ABI acute, so and this again is as of Monday, we had 264 that were in slots receiving services. There were 23 that were reserved, and that's kind of like, so the reserved is kind of like this 4 and 10% I quoted with Michelle P and SCL. They've been given a slot, but they haven't got all the way to the point that they're receiving services yet. And there's 96 available for ABI long-term care. We've got 413 that are receiving services, 15 that are in that reserve, so they're working their way to getting services, and 10 slots.
Will you be kind enough to email that to me? That was a lot of numbers to try to write down all at once. If you'll send that to me, and then I can work. Like I said, I'm working on another project right now with the ABI waiver providers. And so then, you know, that was just mentioned to me the other day that there was difficulty in getting people to the acute. And again, it was just mentioned, and so I can go back and find out more on that. I knew we had this meeting today, and I knew I was on the agenda for today. The other question that's coming up, and I know Sheila has therapy services on there. We're still in limbo on the therapy services, so really no one really had anything to report on that. The other thing they're reporting to me is on the behavior specialist, that the behavior specialists can write the plan, but they cannot be in with the development or I mean, that's a bad choice of words, in with the actual implementation. So they say it creates a problem because they're getting this information from, you know, different sources when they write up the behavior plan, but until they actually put it into effect, so they're not really able to work in with those individuals. So that's a problem, and I know that's something I think Bart has addressed with you guys also, but that's something we probably will be bringing to the legislature in the upcoming session. Is they feel very strongly about not being able to actually work with that person as they implement the plan. So anyway, that's what I have to report, and I appreciate if you can send me the actual numbers on the ABI. But as far as therapy, I think it's just, you know, we're still in limbo right now.
So Mary, I will send you that, and I will ask too if you send me some more details on the behavior, that so that I can kind of research that situation a little bit more and understand what they're kind of
and I think Bart could also help you on that also, but I don't want to speak for you, Bart. I know you're on here, but anyway, I will get the exact. Like I said, I'm surveying the ABI providers, and those was just some things, like I said, that were brought to my attention, but not into any real depth of detail for me to discuss. So anyway, I will work on it.
Yeah, Mary, just copy me on what you send Pam, and that way we'll connect on that.
Okay, sounds good, Bart.
Thank you.
That's all I have to report.
Okay, thank you. Thank you, Mary. Let me know for our January meeting if you want me to put the behavior specialist issue on the agenda. If that
I can say for now, I would like for that to be on there.
Okay. All right. All right. Thank you very much, Pam. Proposed changes in the delivery of mobile crisis services in Kentucky.
Hey, it's Veronica.
Hi,
We
Veronica.
don't really have a substantive update today. We are still navigating the contracting from the request for proposals that we issued for the Administrative Services Organization. Do anticipate that to hopefully get completed in the next couple weeks. And then the next step will be working with the new ASO to develop an implementation plan, which will absolutely include stakeholder meetings. The ASO will hold stakeholder meetings. We'll start working with providers about what the requirements will be as part of the mobile crisis initiative. So, stay tuned for more information on that, hopefully in the next month or so.
Okay. So that's a delay. I think you all had hoped maybe for October.
We had hoped, yes.
Well, hopes are always good, but
as you can see, we have a lot going on.
Yes, you have a few balls in the air, as they say.
Just a bit.
So, and we'll get. I assume when the announcement is made that the contract has been awarded, we will get more details.
That's correct. Yep.
Okay. So that would be the next point of information.
It will be, yes.
Okay. All right. And you want to take us through Medicaid unwinding and sort of recertifications?
Would absolutely love to do that.
I know it's your favorite thing to talk about.
It is. It very much is.
You can do it in your sleep, as they say.
I do. In the interest of time, I'll try to breeze through these a little bit, but please know that we will provide the slides, both Pam's slides and our slides, to the TAC, and then they'll get posted on the TAC page as part of the supplemental to the meeting agenda. So
I will also send them out to everybody who gets my email. So thank you for that. Yes.
Well, I appreciate you taking that action. Want to just note a couple of key flexibilities and strategies we've recently implemented that I think is really great for Kentucky. One is that we are suspending child renewals. And what that means is that starting with October renewals, if a child was up for renewal, we are going to automatically grant that child 12 months continuous coverage. Just as a reminder, we did implement continuous coverage for children back in April. All states are mandated to do that starting January of 2024, but Kentucky went ahead and implemented it as part of our unwinding plan. With continuous coverage for children, what that means is if a child is determined eligible, that child is granted 12 months continuous coverage. And the only reasons why that child's coverage could end is if they turn 19, if they move out of state, if a guardian or a parent has requested disenrollment, like to be moved to other coverage. And of course, if the child passes away, then the coverage ends. But what we're doing now for the unwinding is we won't have to make that determination. We can just go ahead and grant them the 12 months. And then the rules apply for continuous coverage during that period of time. We're talking about 400,000 children that we're going to be able to just go ahead and extend them for those 12 months. So the renewals from October to April of 24, which is the end of our unwinding period. We're not allowed to do it past that time. The other one I want to talk about is we are going to do a redistribution of December renewals. What that means is that states have discretion about how we allocate the cases across the unwinding period. Because there is a bit of a backlog, both in renewals and applications, what we would like to do is to lessen the work in December for our workforce and then reallocate those or redistribute those cases later on into the unwinding period. You will still see some cases that will be in December, because if we're able to go ahead and what's called passively renew the member, so the member has to take no action, they don't have to provide any documentations, we're just able to go out and check the databases and verify their eligibility. We'll still continue to do that. What we won't do is terminate somebody for ineligibility or for an active renewal. If we need a request for information, we will redistribute that case to give them a new renewal date. So they won't even know that that's happened, because we run that at the beginning we'll run that at the beginning. Well, we did run that at the beginning of November. So they won't get any kind of notice if we're not able to passively renew them. But if we are able to, then they're going to get that notice of eligibility that they've been renewed. We also are not going to change any December renewals that align to another program. So as you all may remember, one of the efficiencies that we've done through unwinding is if somebody has a SNAP or TANF case, we've aligned the renewal date for Medicaid with those other programs so that the caseworker only has to touch the case once, because we are renewing Medicaid based on SNAP eligibility. So this way, that case doesn't get bifurcated, so it stays together. And so you may still see terminations in December as a result of that, because if the person isn't eligible across all the programs, then they will lose eligibility for Medicaid as well. And then we will also allow for that if somebody has an income that's above the Medicaid federal poverty level and makes them eligible for a qualified health plan with advanced premium tax credit. So, makes that premium either at no cost or low cost. We will still transfer those individuals for them to be able to access a qualified health plan. So again, December, you're going to see a very small number of cases, but still some activity as a result. And I'll show you how what the caseload's going to look like going forward in a few slides. We also, a new flexibility we've not talked about is that we are extending all populations by 1 month if they've not responded to a notice. So most people who don't respond to a notice get what we call procedurally terminated. And we're trying to prevent those procedure terminations by giving folks additional time to get their response to the notice in. So we've been, for long-term care and for 1915C members, we have been through the unwinding period, extending them up to 2 months. Right now, we just got authority to extend them for 1 more additional month, so a total of up to 3 months. So what happens is if they were due for renewal in October and they didn't respond, we can move them to November. If they don't respond in November, we can move them to December. So we can move them up to 3 months if there's no response on file. Now, the 1 month extension is for all other populations to be able to do that. And again, I think those are helpful to our population, to members going through renewal. Talk a little bit about, we've talked a lot about HCBS and 1915 waivers today, but just specifically how that's going with unwinding. As you all may know, in the HCBS world, that Appendix K is the flexibility, has been the vehicle for the flexibilities we have for the public health emergency. And in order to continue those past November 11th, which was the deadline for those flexibilities to end, we had to implement those flexibilities. We had to incorporate those flexibilities in our 6 waivers. So to do that, we went out and amended those waivers, sent them out for public comment, got a lot of great public comments back. Pam and the team have done a great job of incorporating those, going through, and obviously we'll be responding to them. But we were able to amend those waivers and get them submitted to CMS prior to November 11th, which means we can maintain those flexibilities, including the rates, through the rest of the unwinding period or until the waiver gets approved. We asked for an April 1st, 2024 effective date. It just sort of depends on how that process goes with CMS, because we are not the only state that had to do this. Any state that wanted to extend flexibilities had to amend their waivers to do it. So we'll see what happens with that. But this is a list of the flexibilities that we're going to move to become permanent through the waivers. And so those of you who went out and reviewed the waivers prior for public comment probably saw these. So again, we'll send this out so you all can take a look at it. Just quickly touch base on where we are with our renewals. So 6 months in, hard to believe it. November will be month 7. And just to go through for just the previous month, October, we had 155,000 individuals that were subject to renewal. We were able to approve almost 90,000 of them, which is a tremendous number. And our termination rate is dropping. We had about 12,000, excuse me. I've got a cold. And then the pending bucket means that they're pending processing by our eligibility workers. And you'll see the large extended number. Again, those are because we're reflecting if we've moved a renewal from a previous month. That's in that bucket, excuse me.
You have a question, Bart?
Yeah, real quick. Veronica, while you catch your breath there real quick, I appreciate everything that you are doing in terms of those flexibilities on the renewals. That's really important right now. So I appreciate that. I have a question that this kind of talking with a provider the other day, a light bulb kind of went off in my head of some of what's going on. And so I wouldn't, in terms of, so if you had somebody in, and just making up these numbers, if you had somebody in 2020 or 2021 that got on Medicaid, they were making $9 an hour, and now they're going up for renewal, and they may be making, because wages have changed due to the market and due to inflation, et cetera, and they're making $12.50 an hour. And so now they're no longer eligible for Medicaid because it's a percentage of the federal poverty level. But that $12.50 really doesn't buy them any more than the $9 did because of inflation. So has the federal poverty level that Medicaid eligibility has been tied to, has that been adjusted, or is that lagged behind the basic rapid increase cost of living? Is what I'm getting at.
Yeah, it absolutely has adjusted up. So I think at one time in 2020, it might have been 18,000 something. Then went up to 19,000 something, and now it's like 20,000 something. So yes, the federal poverty level has been adjusted. Is it sufficient? I can't answer that question because I don't get to make that decision. But so the problem is that we did see, for instance, the cost of living for Social Security was a really good cost of living. I know people were really happy about that, but guess what it did? It put them over the Medicaid federal poverty level. And so we're, grappling with that we're seeing folks lose coverage now as a result of that. So it's an excellent point. I think what's important with that, if they have exceeded the Medicaid federal poverty level, that is why it's critically important that we connect them to a qualified health plan. And I'll talk a little bit about that too, although I know we're running up on time. But our goal has been, if you're no longer Medicaid eligible, let's get you covered some other way. Employer, qualified health plan. So we've really worked to try to message that to folks in getting them to move over to a qualified health plan. And we have seen folks do that. We're monitoring it because we want to see that. We're really pushing for that.
Yeah. Thank you.
You're welcome. Reinstatement. So we are tracking if somebody is terminated because they didn't respond to a notice and they realize the next day that, oh, wait, I had a notice I had to respond to, they can still provide the information and we'll reinstate them back 90 days to their termination date if they can do it within that 90-day period. So they don't have to ask for that. It should be automatic, but they do have to be determined eligible for that to apply. But you can see we're tracking those as well. So we're really glad to see that, because if we're losing them because just they didn't respond to notice, we really want them to get back in. We've got a new demographic report out. It's on our Unwinding website. We're really excited about it. It starts in September. We're working on the one from October. Should be able to release that very soon. But it just gives us an opportunity to reflect, where are we seeing trends. There's in the report, it goes down to the county level, so you can see approvals and terminations at the county level. Just again, a way for us to kind of see who is the population being impacted by our renewals. And just overall trends, As you all can see, we've got a 60% overall rate. But I think the good news for approvals, 83% of those are through that ex parte passive renewal. The members had to do nothing. We were able to go out and check and verify all the databases, income, assets, and they didn't have to do a thing. We were just able to tell them, guess what? You've been determined eligible. I mentioned that our redistribution plan. So this is an update of what those projected cases are going to look like. As I noted, there are still cases in December, so we're going to attempt to do that passive renewal for the members, or they may be tied to another program. The renewal is tied to another program, so but a very small number. And then I think the good news is what we're seeing as we keep aligning cases, as we keep implementing our flexibilities, the caseloads are fairly manageable. I'm going to say fairly. It's still a high number, but at least we're trying to keep that manageable. I mentioned qualified health plan enrollment. So as you see Medicaid trend down in enrollment, we want to see qualified health plan trend up, and that is what we're seeing. So that's good news. And then just to note, we are in open enrollment. So we're tracking the fact that, guess what? We've got since open enrollment started, we've got over 1,000 new members, and we're seeing current members renewing. So that's great to keep them covered. So just a plug for open enrollment for qualified health plan. This is for a qualified health plan that's running now through January 16th. After January 16th, you can do a special enrollment if there's a qualified life event. And for anybody who loses Medicaid, there is a unwinding special enrollment. So all you have to do is attest that you lost your Medicaid, and excuse me, between now and July 31st next year, anytime you can come on. Even if you've been disenrolled now, you can still come back on for that reason. Just a reminder to all the folks on here, providers and stakeholders and advocates and members, we have a lot of information on our website about unwinding, lots of flyers. We have a new one about reinstatement to try to help people understand how to navigate the reinstatement process. We're working on a new one about navigating the identity proofing that has to happen to create that Connect account. We have heard that that's an issue for folks, so we're creating a special flyer around that. We'll be circulating that soon. And then our next stakeholder meeting's tomorrow at 11. If you can't make it, we always record it and post it. So at your convenience, if you're trying to get to sleep at night, you can go out there and look at it. It'll probably put you right to bed. But Facebook, Twitter, and Instagram is the best way to stay on top of information around unwinding. If we find out about a scam, we'll push something out about it. So you don't have to do all three, just one, because the same information is delivered on all three programs. So there you go.
Great. And I think your voice almost held out. So rest your voice. And we'll get those slides from you, right, Veronica? Thank you very much. That's excellent information. I'm going to move through quickly. I thought the next agenda item is the interim session, and I thought we would have some of the recommendations from the task forces, but we do not. So I'm going to skip over that. I'm particularly interested in whether the school and campus security task force, which some of us, Steve and I and Joe Bargione, a school psychologist, testified, and we were hoping for some recommendations, but it may not be happening. I need new recommendations to the MAC for their November meeting. Anything from any of the voting members? Steve, you unmuted.
Just in case there was a discussion, I don't really think so. I mean, there's a lot going on. I don't know if there's a recommendation of everything that's taking place, but
that was my feeling too. We've got a lot of balls up in the air. We may need to catch a few before we can figure out what a recommendation would be. For agenda items in January, besides our carryover, I've got the behavioral health specialist issue and the ABI waivers. And then we'll send out both reports of Senate Joint Resolution 54 on the rates. And we'll put that on the agenda to see if there are any questions, and maybe Veronica or Ann or somebody could find somebody, if we formulate some questions that might be able to answer. It depends on how technical that second report is. I do want to get to an issue that came up that I put under new business, and that is that we're hearing that there are problems in schools billing Medicaid for mental health services to students.
That would be news to me. I don't know if anybody else on the Medicaid team has any idea that there are barriers
or problems. Justin, your name came up in this discussion.
Did it? If it was problems, then it shouldn't have been my name. No, I'm joking.
To lay that on you, but
right. No, I know that we had a few. We've been having multiple discussions and talks with school districts on if they were having one of the things that we've noticed, with our new child and maternal health branch, is they reach out to school districts and they run reports and they do research on utilization of all services and school-based services, but in particular with behavioral health services, is that there are a lot of school districts that don't utilize those, or at least they don't bill Medicaid for those. And so we have reached out to school-based or to schools. We've been meeting with school representatives and behavioral health representatives and different groups with Department of Education, trying to see why they're not billing and if there are any barriers or issues for schools to bill for mental health services to students. And so the goal is to make sure that there are not, to make sure that we don't have any goals or barriers up. Number one. Number two, to increase education. So we've went on a kind of a campaign to push for all school-based services and to increase education to school districts on how they can bill, what their options are, all the different ways that they can utilize Medicaid services in school systems. And so that's what I know that we're actively involved in right now. I don't know of any particular barriers in place. We have been able to remove some prior authorizations that and some other administrative burdens that those weren't really specific to behavioral health, but we've been able to do a few things like that for school systems and school-based services. We've been able to open up some contracting options and some telehealth options for them also that have alleviated a lot of issues for large school districts. I know Fayette County being one. But as far as, in particular, I know that this is a topic that we have tried to target because we've seen a lack of billing for mental health services in schools. And so maybe that's what you've heard, is that we're kind of targeting some schools that are some school districts that aren't utilizing those and saying, why? What can we do to help?
Yeah, I think that's exactly it. Is Joe Bargione on? Joe is Joe is my go-to school psychologist, retired, but still working. Does what Justin's report match what you had been hearing, Joe?
Yeah, I think part of the issue, I think, is the concern we have is with some financial resources that are available through Medicaid to bill for behavioral health services for school districts. They're not. I think some of the districts currently, they're using some of those federal dollars, from when they got from the pandemic, to hire behavioral health specialists or practitioners. And then when those dollars go away, the question will happen is how are schools are going to be able to fund those behavioral health specialists? Because with Senate Bill 150, the School Safety and Resiliency Act of 2019, they're trying to shoot for the goal of $1 behavioral health practitioner to every 250 students. So I'm wondering if schools are underutilizing Medicaid as a funding stream, what is it that's keeping them from doing that?
Yeah, that's what we're working on. Definitely is how can we encourage them to increase. We would love to cover a behavioral health professional in every school. We'd be more than happy to do it. But the schools have to be willing to, to bill for that. And so part of our effort is to go out and make sure they understand how they can navigate that process. We'd love to see it. Yeah.
Veronica, over the last few years, have you seen an increase in two ways? One, the number of districts billing for behavioral health service under Medicaid, and also the totals. If I'm, school district X, and I'm billing, say, for over the last 3 years, am I actually billing more time over the last 3 years, or it's relatively consistent, or it's gone down? So the two questions, like I said, one is, are more districts billing for Medicaid? And then the ones who are billing, have you seen a steady incline in reimbursing them for services?
Justin,
yeah, absolutely. So, two different questions. I think there's been it's been stable as far as the amount of individuals that are billing. So we haven't seen an incline in that. When we did the study, when we initially reviewed that. But we did see that those school districts that were billing, that billing increased, had been increasing over time. And so the school districts that are billing are increasing that billing. They're increasing services. They're billing Medicaid more. They're receiving more paid claims. But the amount of school districts that were billing was stagnant. And so that was one of the things one of the reasons why we started this, project and this outreach. And, there's so many different things that, that we're working on right now individually with different school districts. Some school districts have, agreements in place with providers in their community, and those agreements don't really line up with the way Medicaid's built. So we've tweaked and made changes to policy and billing to allow that to work so that they can bill. Other school districts are kind of too small to hire a behavioral health professional, or maybe there's not a behavioral health professional within their immediate area. But there's 2 or 3 other school districts in their adjoining counties that have the same issue. And there's a behavioral health specialist in a county adjoining them. We get all of them together, have them talk. They go together and contract with that behavioral health specialist, and that gives them the amount of students they need, plus and now they all have a behavioral health specialist. So it's very individualized. Our staff's doing a lot of work individually with individual school districts. So that's going to go up as we continue to work with school districts and continue to find these unique solutions to each of their issues. And so that's going to increase as we work with them and as education gets out.
Yeah, I think the other thing to note with that is even if the school might not be billing it up through the school-based services, they have a contract with a behavioral health provider like at FQHC, RHC, or CMHC that's delivering the services and billing Medicaid directly. So those are the two models. The school can do it and provide it, and even if they contract with somebody, they could bill it up through the school-based service. Or they have a provider in the community. They've just said, we want to send our kids to you, or is willing to be the school clinic and bills Medicaid directly. And so that also is something we're really trying to do an environmental scan on, is to try to figure out, if a school's not wanting to do it through school-based, but instead is utilizing a clinic that's billing Medicaid directly. How do we make sure that the services are being delivered?
Right. Karen, you had your hand up.
Yeah, I'm just dovetailing with what Justin and Veronica just stated. There are some school systems that don't want to become behavioral health providers. Mm-hmm. They want to focus on education and have the behavioral health experts handle that. And I know in the life skills region, we've entered into contracts with a couple different school systems where we've put therapists in the schools. That's their work site, and they're part of the faculty and, you know, the community there. So there are different things happening. So just, I think you all stated that you are aware that just because the school isn't billing school-based services, that doesn't mean it's not happening. Yeah.
Right.
Yeah, that's one of the good things about what we're doing, working with each individual district like this, because each one of them's unique. Each one of them has something that they want to do, and each one of them has you know, a different model that they would like to have. And so it allows us, when we go into a school district that's not really billing at all, to say, well, you can do it this way, this way, this way, this way, or this way. And our job as Medicaid is to make sure that we make all of that work for each individual school district, and that we remove any barriers, whether they be administrative or financial, to allow them to be able to do that. And so it's been great work. Erica Jones is our branch manager of that child and maternal health branch. She's done an amazing job. And so we are consistently seeing more school districts bill and provide services and expand services, and like you said, a variety of ways. We've recently started to expand, you know, care in different hours and school-based settings, and there's all kinds of exciting things that we're doing there. But
yeah, that's great to hear. Bart, you have your hand up.
Yeah, just real quick as a resource, and Justin and Veronica, you all probably know this already, but the Kentucky School Boards Association works a lot with and has a whole program for Medicaid billing for their members. And so, yeah, so I was thinking about that would be a resource to, if they could identify, if there's barriers, they would probably be ones that might know what they are. So anyway, that was something I talked with them years ago. So that's probably still in place.
Yeah, I appreciate that. We've been working both with the Kentucky Department of Education and the School Board Association, because as Justin mentioned, so school-based services, or at least services for students, regardless of the model the school wants to utilize, is going to be our focus for 2024. We're really going to, as Justin mentioned, go out there, make sure schools know and understand what's available and how to provide those services, or provide access to those services, right. Probably the better way to put it. And so we've been working on a campaign around that as well, that we hope you'll see a lot more of this in 2024.
Great.
I'm going to put a pitch in for the school nurses, Veronica and Justin, because, you know, there's a big push on to get some funding in this budget coming up to complete the coverage. 59% of our school districts have a full-time nurse in every building, but 41% don't. And if we could get 8.8 million, which is really peanuts in terms of the money we have available to spend, if they're willing to spend it, we could get the rest of those nurses in there, and trying to get the schools to bill for those physical health services that the nurses are providing. So I hope that you are including those as well in your work with the schools.
Yeah, absolutely.
Good. Steve, you have anything to add?
It was said, I think, I mean, everyone said this, the focus is our kids getting services. Doesn't necessarily matter who's billing it, who, you know, as long as, and I think that's the real question I think we all need to ask: is there sufficient capacity in schools for kids? And if schools are doing it, what's the interface with families? You know, how do you make sure all those things happen? You know, so if families need support, they get support. So, and what happens summer months?
Yeah.
You know, there's a lot of questions about how to make this work well for everybody.
Yeah, I think this is an excellent topic, and appreciate the input from Justin and Veronica and the good questions that were asked. Anything on targeted case management policy clarification? I think that.
Sorry, what's asked about the clarification?
Well, I thought there was somebody from, well, there was a question that came up from Tracy Horton at Adanta, and I think in terms of.
Okay, let me follow up with Leslie. I think she was working on that.
Okay.
Maybe with Tracy, directly with Tracy.
Okay.
Yeah.
All right. Thank you.
You're welcome.
Any formulary issues that anybody has? Good. Nobody has any complaints? All right. The next MAC meeting is the week after Thanksgiving. I put 10 to 12:30, but it may actually, that one will be 10 to 12:30, maybe 1 o'clock. And then we'll start the new time frame in 2024. And our next BH TAC meeting will be January 11th. And remember that in January and March, we meet from 2 to 4 instead of 1 to 3, because, all those legislators are in town doing whatever it is that they do, good, bad, or indifferent, hardly ever indifferent. So if there are no other issues to be brought before the MAC, I held you a little bit late. I'd like to wish you all a very happy Thanksgiving to you and your families. And thank you for all of this joint work to make our folks in Kentucky healthier and happier in every way. So happy Thanksgiving to you all.
Keely, you're saying our meeting in March is from 2 to 4 as well?
Yes. Yeah. All right. Thank you all very much. And thank you, Kelly, for guiding us through. Appreciate it.
Happy to do it.
All right. You all take
Happy
care.
Thanksgiving.
Bye-bye. Happy Thanksgiving.